All right. Hello, everyone. I hope you had a lovely summer break. Welcome back to PS Platypus. Today, we're going to be taking a look at our very first clinical skills session. And in that, we're going to be covering the topic of respiratory history or respiratory systems review. So without further ado, let's get started. So what are systems reviews? So if you remember from last year, we would have covered this in quite a lot of detail, but it's essentially another step in your history taking process. Your first step being hand hygiene, followed by introduction. And then once you've done the introduction is characterizing the presenting complaint. So figuring out, you know, WWQQ, so where, when, quantity, quality, aggravating, alleviating factors and associated symptoms, and then also asking about beliefs, impact, concerns, your whole bias for the patient. Next, once you've done that, we move on to the systems review. And that's where you ask more specific questions about a particular body system that really helps you narrow down your diagnoses. And then to finish off your history, you ask about past medical, family, medication, and social history in any order that suits you. Now, in first year, we would have covered this in a lot of detail with MSK system, the nervous system, and the cardiovascular system. But this year, you're going to be learning quite a few more systems, which can seem a little bit daunting, but it also means you have a much bigger toolkit to be able to figure out how to approach different symptoms and signs and narrow them down and then work your way to a provisional diagnosis. So you're going to be learning about the respiratory system, the gastrointestinal system, urinary, endocrine, and so much more. So it's going to be really exciting stepping you through all of those. So in terms of our purpose for doing systems review, just another quick reminder, the way it works is usually, again, your patient's going to come in with a particular presenting complaint. So for example, it could be a persistent cough in this case. And then you start using your clinical reasoning and thinking, what could be the cause for that? So you might think of infective causes like pneumonia, pertussis, cru, RSV, or even COVID. And then you also have other causes like a PE, so pulmonary embolism, asthma, COPD. And again, all these terms will start to make more sense later on once you sort of start learning about these different pathologies and what they mean and what they look like on a patient. And then you're going to start to make that list. And once you have, it's really important that you've got a way to narrow down that list to some of the most likely causes. And that's where systems reviews come in your history. And that'll help you go build a provisional diagnosis, and then present that to a doctor or an intern or anyone else who's asking you about a patient. All right, so with the respiratory history, we start off in the airways. And in terms of the airways, we can ask about whether or not the patient has a cough. And if they do have a cough, it's important that you figure out some really important details about it. So is it productive? Does it bring up anything with it? If it does, we call it a wet cough. If it doesn't bring anything up with it, we call it a dry cough. So very important to figure that out first. And then if it does bring stuff up with it, it's important that you ask questions about what it brings up. So the color of what it's bringing up, is it purulent or like really green and mucousy, or is it mixed in with blood? And here again, you learn an important word, which is hemoptysis. It's really important that you use that word when describing blood mixed in with mucus, because it's what you'll be using when presenting a patient back to a doctor. And very important for your OSCEs in particular. Next, you also have things like amount. So as weird as it sounds, it's possible for you to ask your patient to describe the amount that they're bringing up in teaspoons, and they can try and do that. Although it can be a little bit difficult in some cases, but you can also ask about timing, which is another very important one. Is it more prevalent during the day versus at night versus throughout the day? And also asking about character. So in terms of character, that's sort of the type of cough they're having. So the sound of it. So is it a whooping cough? And again, with all these terms, I recommend searching them up to get a YouTube video or some sort of sound clip which shows you what it sounds like. So whooping cough would lead you to think about pertussis, for example. Barking cough is more so cru or parainfluenza. Bovine cough is more so RSV and left laryngeal nerve palsy. And throat clearing cough, again, that's sort of where something's stuck or lodged in the throat and they're sort of trying to clear that with the cough. That could be postnasal drip, so where some mucus is getting stuck there from the nose, dripping down, and that's sort of trying to clear that with the cough. Sinusitis and GORD. The last one there, GORD, is something you'll cover in more detail in your GIT system. So I won't talk too much about it now, but it just shows that these histories are very much interrelated. And even in a patient who's just got a cough and you might think, oh, that's a respiratory system thing, you would still ask about other systems, like, for example, the GIT system. because it could be a pathology in that rather than just a respiratory pathology. And next up in your airways, you can also ask about breathing. So with breathing, you have things like wheeze and stridor. So wheeze and stridor being whistling sounds that come from the airways when they're breathing in and breathing out. So wheeze is more so when you're breathing out is more so breathing out is there sort of a high-pitched sound coming from the airways, and that would be associated with some pathologies like asthma, for example. And stridor is the same thing except when you're breathing in. You also have shortness of breath or dyspnea, which is the medical term for it. And then finally, you can also ask about snoring, which is characteristic of something called obstructive sleep apnea, which again, you'll be learning about later on. In terms of snoring, you can ask whether the patient has noticed that they've snored at night, or you can also ask, has their partner reported that they've been snoring at night? And both of those work. Next up, you also have chest pain. And I've put this here with airways because in particular with chest pain, it's important to know, is it worse on breathing? And again, that'll be another factor you'll take into account when thinking about the diagnoses. Something you might see on the right of the slide here as well is I've also talked a bit about how the color of what's being brought up in a cough can relate to a pathology. So for example, you'll learn that red and pink frothy mucus could be pulmonary embolism related, whereas if it's more rusty colored, it could be pneumonia. And if it's more bloody, so that's hemoptysis, it's related to, for example, violent coughing, because you can imagine that if you cough very vigorously and violently, it might shear some of the blood vessels in your mucus lining in your respiratory system, and that can bring up blood with it. Or it could be, as you've explained before, a nose-related thing. So if you have a nosebleed, so epistaxis is the medical term for it again, then the blood from your nose can drip down to your throat. And so what you're coughing up isn't related to your lungs or anything down there. It's to do with pathology up in your nose. Then you also have lung cancer. Cancers can always leak out a bit of blood, which can be brought up. And then bronchiectasis, which is again something you'll cover later on. So I won't talk about it too much here. And then with timing as well, something you can additionally do to characterize the cough is if it's less than 3 weeks for how long it's lasted for, it's characterized as being acute. Whereas if it's been present in the patient for over 3 weeks, we sort of characterize it as being chronic. That's sort of a common theme you can use across multiple different symptoms. So you can use acute versus chronic for pain as well. But we're using it here for a cough. All right, so now that you've asked about the airways, which is sort of the main area for respiratory systems review, you also ask about other areas of the body. So for example, you might ask about the face. And in particular with the face, we only ask really about one thing, which is facial pain, and that's related to sinusitis. So you'll learn about your facial sinuses both this semester, but also in a bit more detail next semester during head and neck anatomy. But those sinuses can become inflamed, and you can have a look at what they look like on the screen there. And on examination, you'll also palpate them, but we're not going to cover that too much here. You also have your ears, and they can be painful, blocked, or discharging. So it's important to ask about that as well. And you also might be wondering, how do your ears in any way relate to the respiratory system? Again, you'll be learning a bit more about that next semester during head and neck anatomy. But your respiratory system, so your pharynx, is very much related to your ears through what's called the eustachian tube. And so you're going to be learning about that later on. And so infections of either system can move up or move down. That's why it's really important to ask about that. You also have questions about nose-related things, so post-nasal drip. So do you have sort of mucus from your nose dripping down to your throat? Runny nose, which is called rhinorrhea, sneezing. So you can just ask about generally, have they been sneezing a lot more than usual? And then you also have nosebleeds, which again, we give the medical term for epistaxis. You also have throat-related questions. So do they have a sore throat? Do they have a hoarse voice? Then you have your more systemic questions about fevers, night sweats, malaise, myalgia. And again, a lot of them are related to infection or cancer and more systemic pathologies. And then finally, optionally, you can also ask about equipment and devices. So are they using puffers? Are they on a ventilator? Things like that. You'll normally be able to see that with a patient. And And so often we cover that more so in examination, but you can always ask about that in history if you have time to. So just to sort of guide you, I've got what's called the respiratory history script, but I put the word script in quotations because you shouldn't really try and use this, as is. Ideally, you want to figure out the best way for you to ask these questions. So it's more so a guide, and then you can modify it for what works best for you in terms of how you can most comfortably speak with a patient. And however you use this list, it's important that you really avoid using medical jargon. So if I have used any of it here, try and steer away from it and see if you can find an easier way of explaining a topic. So that's all there for you. And if you're looking for a way to remember all of this, again, I recommend the whole approach of thinking about airways, then moving on to your face, ears, nose, throat, systemic. But if you're looking for an acronym, there's one you can use, which is PC dense. It's not in the same order, but the way it works is the P stands for chest pain or pain. The C stands for have they got a cough. The D stands for dyspnea or shortness of breath. And then your ENT is ear, nose, throat. So you can ask about all those things there. And then S is systemic. I've left out face there, but you can probably add that in somewhere in the acronym. And so that covers it for the respiratory systems review. But you can also do what's called risk factor scanning. So during the other parts of your history, think about other factors that might play into a person being more likely to have a lung pathology or respiratory pathology. So for example, smoking, a very, very big one. Asbestos exposure, also a big one. Same with pollution and dust exposure. Allergens that they might have been exposed to, medications. So one thing you'll learn very soon is that something called ACE inhibitors, which I think you might have covered last year, they are known to produce a dry cough in patients. But again, you'll be sort of learning a huge list of these later on, so I won't present them all to you right now. And so you also have things in your past medical history, which might relate to risk factors. And then you obviously have your family history. So if any relatives have a respiratory pathology, there's a higher chance that the person you're seeing also has one. All right, so it's very important that you start to realize in second year, rather than just checklisting and working your way through the questions, while that will get you through your OSCEs and be fine for that situation, it's very important that you also start tying in things like your history and examination with actual conditions. So as we go through the year, I recommend making a table of the different conditions you're learning, and also the relevant history findings and examination findings, so that when you're doing an OSCE or when you're practicing, you can start to move beyond just asking questions and thinking about actual diagnoses. And again, we at PS Platypus will be trying to do that as well. We'll probably get a table going, but I recommend you make one of your own and review that frequently, just so you can get a better idea of what to link in your signs and symptoms to in terms of pathologies. All right, that wraps it up for the respiratory systems review. If you have any questions, concerns, or even feedback about what we covered today, please let us know in comments or send us an email or even reach out to us individually on Messenger or Facebook, and I'm sure we'll get back to you. I believe we also have a Curious Cat this year, which you can have a look at for asking any questions. But this is very much an introduction to systems review. And so we'll see you again next week.